Dr. Sandy Anderson. I am a dermatologist, associate specialist at Royal Cornwall Hospital. My background's been in general surgery and general practice before full-time dermatology with a special interest in skin cancer and complex reconstructive surgery. So before Isla, our workflow was very traditional. So GPs would refer patients with suspected skin cancer, and we would see every patient face-to-face. That would be the first thing that happened, would be a face-to-face appointment, ideally within 2 weeks, with a dermatology specialist, so either one of the medical team or a specialist nurse. So the integration with Isla has been something we've worked quite hard on, and the Isla team have worked hard on. It's integrated very well, so we've worked to try and reduce the number of IT systems that our doctors need to look at once. So our referral letters appear on Isla now. When patients come to our image capture clinics, that Isla is the only system in use. And when I'm reviewing the images and the patient data afterwards, I only have to have Isla open for all the outcomes, and then we need one other system open to book patients for procedures who need to come back. But that integration's worked well, because the risk when we were looking at it was that we might have to have 4 or 5 applications open at once, and that's not a great situation for us. The thing about Isla that's different to a lot of our other systems is that everything that's entered into Isla can be coded and can be retrieved in a coded format and in spreadsheet format. So we've been looking to collaborate with other units to build up big research databases of images and tag data for a number of different kind of research purposes. And the fact that Isla's everything can be retrieved and then represented as you would choose has been great. And the other thing is that some of these other units have collected data in a slightly different way, and we've been working very hard to standardize our format. So across different units, we're collecting the same data in the same way, so that we can then integrate into anonymized research databases. So Isla's been, the team have been really flexible in that, and we started with one data set, and we've tweaked it a little bit as we've collaborated with other units to align everything. The biggest thing that Isla's done for us is to reduce the number of face-to-face unnecessary consultations for benign lesions. So we've been able to give 25% of our referrals, we've been able to give those patients remote advice and refer them back to their GP without them needing to come and see us. But in the consultations, one thing Isla's great for is for patients who you have to see on more than one occasion, or you want to follow something up, then it's very good at presenting images in a way, a standardized way, side by side, and letting you see change over time. And opening the patient record, then you can easily ping up different images to compare side by side. And so that we haven't really had a system that's been flexible in that way before. So that's something that's we're moving more towards, monitoring appropriate lesions rather than as in a way of avoiding a biopsy for that lesion. And Isla's been good for that. Yeah, so there's, with the new system that we're adopted of patients attending remote imaging clinics and data capture clinics, and then me reviewing, or my colleagues reviewing the Isla data offline, as it were. There's more remote advice to patients, so we're seeing less, which means we're having to advise more remotely. And Isla's been flexible to allow us to put direct comments to patients into the Isla outputs, which then are generated in letters. So it's fine for that. We've been careful to give appropriate caveats and kind of safety netting with our patients that we're not seeing face to face. So we've added some very kind of general advice to patients at the end of letters, saying and to GPs, just saying exactly what's been examined and what hasn't been examined, and that patients might need to see their doctor if they have any other lesions that haven't been looked at, or for a skin check. So we're quite we're not taking any risks with our cancer management with the new system with Isla. I think Isla's benefiting a lot of patients. So we have 10,000 patients a year who are referred with possible skin cancer, and about 30% of them will end up with skin cancer. So the other 70% potentially don't need to see us or could be managed in primary care. There's a condition called Bowen's disease, which is a precancerous sun damage condition, which can usually be treated successfully with creams. And you can only detect it with some very close-up magnified images down an instrument called the dermatoscope. So with the community lesion imaging clinics, which is using Isla, our healthcare assistants can put the magnifying device directly over the patient's lesion onto the skin, and take a 10 times magnified picture in really sharp focus that comes up when I review the patients on Isla. And so you're looking for some very fine detail and very sharp microscopic almost features, but you can identify them and then confidently write to the patient and the GP and say it's confidently this Bowen's condition rather than a skin cancer, and it's safe to treat with a cream, and they don't need an operation and they don't need to come to hospital. And that makes up a significant proportion of our patients. And I think for them, the other thing about Bowen's disease is that it's a disease of elderly people usually, and so they're often quite frail. They often have transport difficulties. A lot of them live in quite remote parts, since we're in Cornwall, in quite remote rural areas. And so being able to write to those patients who've been seen locally in a community clinic and say you don't need to come to hospital can mean quite a big deal to them. We haven't yet had formal feedback surveys of these community lesion imaging clinics because it's quite a new initiative, but we've had quite a lot of informal comments, and the patients who I see back in clinic who've been through that process and needed to come to hospital afterwards have been extremely positive about the experience. And I think with Isla, it's a structured questionnaire that they're being asked, which takes probably 5 or 10 minutes. And patients really appreciate the detail that there's been, and the fact that they've been, they feel listened to, and they feel they've had a very thorough assessment. Because traditionally in dermatology, assessment of a skin lesion might be very brief from a specialist, as in less than a minute of actual patient assessment. And so I think this process, patients are given an opportunity to say what they would like to say and answer questions in a structured way. And so I think they feel it's a more thorough experience. The biggest thing for me with Isla is that it feels like a non-medical commercial IT application like you might use in everyday life. Especially in hospital medicine, IT's always been or often lagged quite far behind normal kind of non-commercial or non-medical software applications. But Isla feels much more like using an up-to-date kind of cloud-based. The fact it's cloud-based, the fact it feels like it's designed for images and designed for Windows. Whereas a lot of our traditional systems have felt more like they're kind of bolted on and not quite, not slick and a bit clunky. So I think that's the thing for me, and the ability to just look at images in great fine detail, but and retrieve them very quickly and move around quickly, and it just feels more natural experience to use it, and probably engenders less delays than the traditional hospital software applications. So we've started Isla, or with Isla, with skin cancer, suspected skin cancer referrals and community imaging clinics in a very stereotyped way. But that's only half of our work in dermatology. So the other half is patients referred with inflammatory conditions, so rashes, things like eczema and psoriasis. and we are looking to see how much of that work could also be done remotely or semi-remotely. And one area that we're particularly interested in is patients submitting their own images, which is possible with rashes and inflammatory conditions. And it might be that whereas with the cancers we do need to see people in a clinic to use our dermatoscopes and obtain a magnified image, it might be we can manage some patients 100% remotely, which is quite an exciting concept, especially for a rural community like Cornwall. So on our traditional pathway, we would see 100% of patients referred with suspected skin cancer face-to-face. Using the community lesion imaging clinics and the Isla platform, we're able to avoid 50% of those face-to-face appointments, which is a combination of patients who have benign disease that can be referred back to the GP for management, and patients who obviously need a procedure, such as a biopsy or a excision of a skin lesion, who can then be added directly to an operating list and brought in straight to that appointment, rather than needing an interim appointment to meet us to arrange that. And that's been the biggest advantage of Isla for us. So in terms of timings, a traditional face-to-face clinic would be in a 4-hour block, and we would see between 12 and 15 patients in that time with suspected skin cancer. In terms of the Isla reviews, I can review between 40 and 50 patients in that same 4-hour time period. So that's obviously a significant efficiency saving, I guess you could say. And if saving efficiency means there's more capacity to treat patients and more capacity to do operations for those who need it. Forwards, breath of fresh air.